This is good. Bismillah Rahman. Okay, guys. Since yesterday we are trying to solve the issue of first year. This first year is very smart first year, you know. By default, it happened that one of the group has an advantage. So they have little bit time in the morning. So group A, I think. Everybody is coming, I want to group A, I want to group A, I want to group A. The whole batch goes to group A. Then we notice what is the issue. Oh, this is the issue. They are free in 1 day, they are free almost. Okay, no problem. It's very simple. So yesterday your leader Hassoon and the third year leader, the fourth year leader, they were there, the final year leader were there. I said, you guys were not this much smart, they are very smart and they are enemy of each other. So inshallah we will be in peace, because one group don't want that another group has an advantage. So now I said, okay, no problem, we'll do equality, inshallah. All of them they will come 8 o'clock and all of them they will go 4 o'clock. Okay guys, Bismillah ar-Rahman ar-Rahim. We'll see some quick things about the digestion and absorption. Although you know that this topic is like start from the class 8th and it remain there till Khabar. This digestion absorption don't go away. So we will see what is digestion and what are the mechanism, how the food stuff goes, they break down, which starts from where, and then we will see some of the important clinical things regarding these digestion and absorption. So we know that this is the process of changing of food into the smaller or simple component, and then that will be to convert the higher molecule into a smaller molecule so that it can be easily absorbed. So the first step is the digestion to convert the bigger molecule. We take carbohydrate in the form of polysaccharide, we take protein in the form of protein, and then we take complex lipids, higher lipids, and then the digestion starts. Some of the nutrients their digestion start right from the mouth, and then some are broken down in the stomach with the help of its grinding mechanism, then goes down into the intestine, and then finally they are converted into smaller particles, and these smaller particles they are absorbed, and then again the process reverse in the body. These smaller particles either they are utilized by themselves or they are converted into the complex things. For example, we take protein broken down into amino acid absorb, enter into the body and again synthesize protein, again synthesize larger molecule. We take carbohydrate is broken down into monosaccharides, smaller sugars, then they are absorbed, enter into the body, some of them they are utilized, other they are stored in the form of glycogen. So I mean, we take short chain fatty acid, long chain fatty acid, they are broken down and again in the body they are converted sometime into short chain, sometime into long complex lipids and so on. So this is the mechanism. And if you see the digestive tract, the gastrointestinal tract where the digestion took place, it starts from mouth, esophagus, stomach, small intestine, large intestine and anal canal and then away. So this is the whole mechanism. So starts from here and then out here. The stomach actually it has two mechanisms. One is the collection, another is the mixing, the grinding mechanism. And the volume range 0.5 liter, tamam, up to 6 liters, depending upon your capacity and capability and love with the food. Either you can be a big sheikh with the 0.5 liter or either you will be very smart with the 6 liter, but it can. The technical issue with this stomach is that the innervation is like such, anatomy people will let you know and neuroscience people will let you know, that if you cut this stomach, it is not painful. If you burn this stomach, it is not painful. If you grind this stomach, it is not painful, but if you distend the stomach, it is painful. So pain sensation is such that distension will give you the pain. So gastric gland secrete gastric juice, which comprise of water, some enzymes, hydrochloric acid, and that kill most of the bacteria, and then begins the lipids and protein digestion. Mucus protects the lining. Chyme is a semi-liquid solution which is present there. Then there is a pyloric sphincters which regulate the passage of the chyme into the small intestine. Now if you see the secretion of the digestion, this is the basic one, this is the acidic one, and if we start from here, if we take this 7 as a water and saliva, and if you go up, you will be having more alkaline, and if you go down, you will be having more acidic, and all these things are present in the body. So we have this one bile, we have pancreatic juice, saliva, and then this gastric juice, highly acidic gastric juice. Approximately 90% of the digestion, essentially all lipid digestions, takes place in the first 2 sections in the of the first 3 meters. First 2 sections of the first 3 meter long intestine, and small intestine has 3 segments. One is the duodenum, where it is connected with the pancreas and the bile, and then jejunum, and last one is the ileum, where most of the absorption took place. Here if you see, the liver gives you the gallbladder, liver and gallbladder will give you the bile fats, digestion is there, pancreas, amylase, and then carbohydrate, sodium and bicarbonate, and it neutralizes, because most of the pancreatic juice, it neutralizes most of the food component and the chyme. Now the food which comes from the stomach to the duodenum is chyme. It is acidic in nature. As soon as this acidic nature goes down into the duodenum, duodenum is not sensitive to, duodenum is very sensitive to the acidic part. So as soon as it enter into the acidic part, into duodenum, because it is very much sensitive, it gives sensation to the brain, and then pancreas pour its secretion into the duodenum. So in order to neutralize, otherwise there will be a problem in the duodenum and it leads to ulcer. That's why if there is a huge situation of GI disturbance with the, so you have peptic ulcer and gastric ulcer, and sometime if the situation is too much worse, even this goes down, high concentration of the acid will lead to ulcer in the duodenum and so on, like as it done in the esophagus. When there is too much eating, bad habit, bad situation of the sleeping, so what happened? There is a reflux esophagitis, and when there is a reflux esophagitis, the esophagus is not meant for that acidic content, and then there is a transformation of the epithelia, and this transformation of the epithelia lead to a situation that is known as Barrett esophagus, and finally Barrett esophagus leads to adenocarcinoma. C. esophagus. Large intestine colon reabsorbing mechanism and elimination, and some of the fermentation of the undigested food, bacteria are there, and then it terminates at the rectum where water and some minerals are absorbed, and finally anal sphincter control the anus, and once the defecation process starts, we excreted the residue and the waste product. So this is the mechanism. This is the mechanism here. It starts from, it comes here, end of the small intestine, from the cecum, this is the appendix here, and then ascending colon, transverse colon, descending colon, and then sigmoid colon, rectum, and then so on. Absorption, end products, carbohydrate into monosaccharides, fats, higher fats, short chain fatty acid, they can directly be absorbed from the, even from the mouth. Sometimes this is again a misunderstanding of the people, that the doctor say, okay, it's all right, you don't take this, but okay, no problem, milk is okay, although milk contains short chain fatty acids, so they absorb directly. They are also called volatile fatty acids. Long chain fatty acid broken down into glycerol and fatty acid, triglycerides broken down, proteins into amino acid, vitamin, minerals, they are absorbed as such, and then this process of absorption took place, the carrier load of the nutrients outside, and then they are transported into the inside. This is the facilitated diffusion, simple diffusion, and then active transport with the help of energy. So we have 3 basic mechanisms. Some goes with the facilitated diffusion without anything requirement, some need specific proteins, while the other needs active transport. What is the importance of active transport? You gentlemen. Yes, active transport. So, absorption occurs in the small intestine. Wall of the small intestine is covered by higher thousands of the fold, hundreds of the folds. And then each of the fold is covered with the villi, and each villi contain again microvilli. Villi, folds, villi, microvilli, they all are to increase the surface area. To increase the surface area. Otherwise 8 meters of the intestine. So to increase the surface area, the more is the surface area, the more easy will be the absorption. That's why, so this is how the villi and the microvilli, the bunch of the villi and the microvilli occurs. In old ages, what happened? Gastric atrophy happens, and some of the absorption process is decreased because of the age dependent atrophy of all these villi. So here stomach starts, like if you see the site of the nutrient absorption, only with this one, but anyway, small intestine, here short chain fatty acid also goes inside, glucose, water soluble vitamins, then sodium, potassium, vitamin B12, water, fats, amino acids, colon, sodium and potassium, and then rectum, all these things goes out. Transport system, we discussed 3 major mechanisms, and then it enters into the vascular system of the body. Water soluble nutrients, monosaccharide, they goes directly and enter into the blood via the portal vein for the transport to the liver. Lymph system is there, meant for transport of fat, because it comes in the chylomicron form. So it comes to the lymph, and then the lymphatic system, it is connected again to the venous system and then enter into the blood. Transport of lipids, since fats are insoluble, they must be packed with the transporters like lipoproteins, and then these lipoproteins are rich with the triglyceride, rich with the protein, and less with the cholesterol. So as the density goes, like for example very low density chylomicron, very low density, then high density. So lipid level is increasing, very low density, then low density, and in the high density the lipid level is decreased while the protein level is increased. That's why very low density are dangerous, whereas the high density is less dangerous. So this is how the complex picture. It will go on, okay, by itself. Okay, so here if this is just a complex picture. We have protein, we have lipids, we have carbohydrate, and this is the structure. This is the mouth, stomach, then intestine, small intestine, then large intestine. This is the gastric area, the stomach area, then small intestine, then large intestine. So once if you see it very clearly, you will see that protein start here in the pepsin, then pepsinogen, and then goes down to a small amount polypeptides and then absorb. Here if you see, this is the whole structure. Now it's a little bit clear. Lipids start, although it starts from the tongue, lingual lipase act on the lipid, broken down into fatty acid and glycerol, but then goes down, and in the stomach the grinding action is there, but later on it goes to the pancreas. With the help of the pancreatic lipase, they are broken down into fatty acid and glycerol, and then it goes absorbed. Similarly, carbohydrate starts from the mouth, salivary amylase, and then in the stomach, just because of the grinding action broken down, then goes into the intestine with the disaccharidases, and then different others saccharadases are there, they are broken down, then amylases are there, pancreatic amylase is there, and it comes and broken down, all these things, chymotrypsin, trypsin, and then it goes absorbed into the form of monosaccharides. So this is how the whole nutrients are absorbed. Fatty carbohydrate principally consists of the polysaccharides, also contains some disaccharides broken down into monosaccharides and then absorbed directly without any additional mechanism, But one mechanism is very important for the absorption of the glucose.
The glucose transport.
Glucose transporters are there, GLUT1, GLUT2, GLUT3 transporters are there. And in addition to this, the glucose transporter, there is one more mechanism which is required for the transport of the glucose. That is that it transport along with sodium. It has a very good friendship with the sodium. So the receptor is such, co-transport. The receptor is such that it has two facets. I don't know it is there or not. Maybe somewhere. It has two facets. On the one facet there is a sodium and the other facet there is glucose, and then they go simultaneously. That is why if somebody is suffering from diarrhea and he lost water, so in addition to this you give him some oral replacement therapy, and when you give them oral replacement therapy, although he is losing water, when is losing water, in addition to the water it loses sodium as well, because they have a very strong connection. Now you wanted to replace sodium, you wanted to replace water, but in addition to this you also add sugar in it, because until the sugar is not there it will not go inside. So it is like this. Pancreatic amylase, it's also an alpha amylase, optimum pH 7.1, like ptyline, which is present in the tongue, and then hydrolyzes 1,4-glycosidic linkage. And if you remember your prep year, there are two types of the linkages, 1,4, 1,6, 1,4, 1,6. 1,4 is the straight chain and 1,6 is in the branch. So carbohydrate, lactose broken down by the lactase, maltose broken down by the maltase, and then sucrose broken down by the sucrase. Then it absorbs into the small intestine and delivered into liver by the way of hepatic portal vein, and the rate of the absorption diminishes from above downwards, so higher proximal duodenum, 3 times greater than the distal ileum. And after the liver process the nutrients enter into the bloodstream, and then it is transported to all over the body. So this point is very much important. The proximal part has 3 times higher absorption as compared to the lower part. If you see the rate of absorption of the different nutrients, so galactose 110 times, glucose 100 times, if you take the example of glucose, fructose 43 times, mannose 19 times, so more faster than this one, and then this one. Now what is the mechanism of the absorption? Simple diffusion. We see 3 types: active transport, and then some of the and sometime it is with the facilitated diffusion, facilitated transport. Then there is one of the hypothesis, which is we call it Wilson-Crane's hypothesis, and it shows that the sugar which are actively transported have several chemical features. So commonly they suggest that it should be actively transported have following: they must have 6-member ring, those sugar which are actively transported. Secondly, they must have 1 or more carbon atom attached to carbon number 5, and thirdly they must have an OH group at carbon number 2. So when these characteristics are there, they said that these sugar should be the common. They suggest that to be actively transported, any sugar which required to be actively transported at least have these 3 characteristics. At least they have these 3 characteristics. So we say, okay, this is the situation. You have OH, you have carbon at carbon number 5. So we say, okay, all the sugar they are transported with the simple diffusion, facilitated diffusion, but some of them they are actively transported. Though they are actively transported, must have these 3 characteristics. Again, in some of the higher exams these type of the questions come, because we have our mind that sugar very simple like this. Some carrier proteins are there, and these carrier proteins it has 2 binding sites, one for the sodium as I said earlier and another for the glucose, and these carrier protein is specific for the sugar, and it is mobile, and it is sodium dependent, and it is energy dependent. So these carrier proteins are there. Here you can see this, you have sodium side, you have glucose side, and then they deliver glucose, and then sodium goes back again, enter into the system, and then goes on. Some transporters are there from GLUT1 to GLUT7, and they have very much important role in different areas. So GLUT1 red blood cells, GLUT2 liver and kidneys, GLUT3 brain, kidney and placenta, GLUT4 skeletal muscles, GLUT5 small intestine, GLUT7 liver, endoplasmic reticulum. Now here, if there is a problem here in the skeletal muscle, adipose tissue is hard, so the problem will be in the GLUT4. Tamam. So in diabetes the issue will be here. Tamam. If this is the problem, glucose will not go into the muscles, and then there will be high level of the glucose. Now what are the factors they affect the absorption? Several factors are there. You have status of the mucous membrane. If the mucous membrane is healthy, good, fine enough. If it is not healthy, it creates problem. As I said earlier, in the old age there is a absorption problem. Hormones, thyroid hormone increases the absorption of hexoses and act directly into the intestinal mucosa. Adrenal cortex absorption decreases into adrenocortical deficiencies. Anterior pituitary absorption mainly through the influence of thyroid hormone. Insulin, no effect on the absorption of glucose. No effect on the absorption of glucose. If you see the mechanism of the, okay, we'll come to this later on. Vitamins, but it has an effect of transferring of glucose to the muscles. Tamam? Vitamins absorption is diminished in the state of vitamin B deficiency, particularly thiamine, pyridoxal and pantothenic acids. And they are all required for the good state of the villi. The whole process of digestion, lipid and fat digestion, directly lipids and its subsequent absorption may be divided into three phases. Phase 1 is the preparatory phase, where include the digestion of the lipid from the mouth to the stomach. Phase 2 is the transport phase, include the digested fats across the membrane of the intestinal wall through the intestinal epithelial cells, and phase 3 is the transportation into the blood circulation. So phase 1 digestion, phase 2 packaging, phase 3 transport through the intestinal epithelial, and then continuously phase 3 into the transport into the blood circulation, because we know that fat are insoluble in water. Insoluble in water. The stomach fats broken down into glycerol and fatty acids, and then initial digestion start in the mouth, lingual lipase, and then so on, as we discussed earlier. So here it starts, like for example here, lipase, this is the triglyceride, fatty acid with a glycerol, and then lipase act on it. So there will be fatty acid, this is the fatty acid, OH come, diglycerides, then lipase act on into, then diglyceride shift to monoglycerides, and so on, and fatty acid is absorbed, glycerol goes to the portal circulation. You have triglyceride, 3 fatty acids, diglycerides, monoglycerides, glycerol and fatty acid. Fatty acid goes into the circulation, glycerol goes into the portal circulation. Recycle again, then inside the body again they synthesize the same thing, they synthesize triglyceride and they synthesize higher lipids. Lipids fat digestion and absorption increases with the help of bile, and when the food is with the high lipid content enter into the stomach, the hormone gastric inhibitory peptide GIP is released, slowing down the movement outflow of the stomach, and this is why we feel full after the eating of this fatty food. And this is again very much important, this GIP helps, it has two mechanisms. When it is released, it slowing down the movement flow out of the stomach, because fat has to be broken down, and there is nothing in the stomach except for acid and the grinding mechanism. So when you have high fat diet, high fat diet will do two things. One, your satiety will be reached to that point, so you will not eat further, point number 1, and point number 2, this GIP is released, so your stomach will work more, so then it will be broken down into smaller particles. Clear? That is why and fat is bitter in taste, fat is bitter in taste. So, whenever you come to the fat content, too much fat, you stop eating, you stop eating. You love sugar, you love protein, but when it comes to the fat, and try this, when you have some dish with where the fat content is too much, when the fat content is too much, you stop eating once you come to the fat. Similarly, it is in the milk, normal process of milk, when the baby start drinking milk, the first component of the milk is carbohydrate, start milk, sweet in taste. Then there is protein content, and it is said that last component is highly rich in the fat. So when it comes to the fat, because fat has two components, one is it is bitter in taste, it is bitter in taste, and second, it causes the fullness, it reaches to the level of satiety. So then the baby is full, and then it no more further feeding. So here the same situation, stomach, this is the stomach, small intestine goes to the small intestine with the help of the gallbladder, and then they absorb into the blood, and then from the blood it goes to the whole body. So resynthesis of the TG inside the body, as we discussed earlier, this fat and glycerol enter into the portal circulation, enter into the blood, reaches to the liver, and then in the liver again they are, or in the peripheral circulation they are, in the adipose tissue they are resynthesized. So the smaller larger molecule broken down into smaller molecule, these smaller molecule enter into the circulation, and in the body they synthesize again TG. So in the intestine, monoglycerides, monoglycerides, high level of the monoglyceride, then glycerols or diglycerides, and in the body again they synthesize intestinal lipase, thiokinases, and then they intestinal epitheliums, and then again they are broken down into triglycerides, synthesized into the chylomicron, and then chylomicron enter into the blood circulation, reaches to the liver. In the liver it is broken down, it is broken down into VLDL, the VLDL enter into the circulation, and then endothelial lipases act on it. When it is act on it, fatty acids are removed, and DGs, glycerols are removed, enter into the adipose tissue, and in the adipose tissue there is synthesis again. Protein digestion splits into linked amino acids by the peptidases into individual amino acids. The stomach, enzyme, pepsin start breakdown of the protein into smaller units of the polypeptides, and then in the duodenum of the small intestine and the pancreatic enzyme trypsin and chymotrypsin is split protein into polypeptides and peptides. So this is the pepsinogen, HCl activated into pepsin, and then you have active pepsin, inactive pepsin, and they break the protein into smaller peptides. This act on the trypsinogen. Trypsinogen is proenzyme or zymogen, like pepsinogen is a zymogen, it is a 362 amino acid. HCl act on this, or pepsin act on it, this pepsinogen, and convert this pepsinogen into active pepsin, and it has three components. One is active pepsin, which is 320 amino acid, another is inactive component, inactive and small peptide of the 42 amino acid, and this active pepsin again activate this pepsinogen. So depending upon the HCl and depending upon the pepsin, pepsinogen is converted into pepsin. Similarly, trypsinogen, which is inactive, enterokinases act on it, trypsin act on it, the reverse trypsin, and divided into two. One is active trypsin, another is hexapeptide. Hexapeptide, how many amino acid will be there in the hexapeptide? Yes. Where is that another gentleman who was here with the white coat? He left now. 6. He was sleeping, he was doing something, and when I asked question, now he left. But no problem, he will come again. His name is Ibrahim al-Rashid, I think. I think so. No problem, he will come again. So, and trypsinogen, active trypsin, and then this trypsin again acts on it, and then reactivation of these enzymes. And when these are activated, so here chymotrypsinogen into trypsin, then chymotrypsin, theta chymotrypsinogen into more chymotrypsins, and so on. And this one is the active chymotrypsin with the inactive dipeptides. And then Proelastasis converted into elastasis, fibrinogen converted into fibrin. All these are function of the trypsins. So, once in the liver, one of the three things happen with the protein. Number one, it converted into glucose. Which amino acid? Which amino acid?
Alanine.
No, no, in broader term of this. Broader term of this. Glucogenic. Glucogenic. Glucogenic amino acid. Converted into fat and directly released into the blood. Directly released into the blood. Fat, mana ketogenic amino acid. Ketone bodies and fat, ketogenic amino acid. So three things happened. Vitamin absorption, we don't need anything, too much things except for some, are absorbed mainly in the jejunum and ileum section of the small intestine. A, D, E and K are the fat soluble, so they will be absorbed similarly as the fat. However, fat is transported from the for which of the vitamins are delivered into the liver with the fat like chylomacrons. B and C vitamins are water soluble and they start breaking down into the stomach throughout the small intestine, and they do not remain in the body tissues very large, long enough, and so that's why whenever they absorb, they go to the urine, except for a very little amount of B12. B12. Maujud, but little bit coming in later. Intestinal absorption, minerals increases when the body is lacking particular nutrients. So whenever there is a lack of one, the absorption is increased. Intestinal absorption of the mineral decreases when the body is not lacking the particular nutrients. So it is very much well balanced, controlled. Water, saliva, gastric secretion, bile, pancreatic acid, intestinal secretions, all are approximately 7 liters of the water when combined with the intake of average 2 liters of the water ingested in the body process. So approximately 9 liters water daily. 72% absorbed in first half of the small intestine. 20% is absorbed in the lower half. So 72-20 is 92%. Tamam? And 6% is absorbed in the large intestines. So 72, 92, 92 and 6, 98%. Totally reabsorbed. This body, smart bodies, fluffy smart bodies, I'm the old one, I'm referring to you guys. 92% is water. Everything is water. If you take plasma, if you take 5 ml of the blood, you spin it, tamam, and there is the plasma, and you take a 1 drop of the plasma, 1 drop of plasma, 90% is water. So the whole body is water. If the water is removed, then the person is gone. That's why fluid electrolyte balance is very important. And honestly, I tell you, in the whole medicine, no medicine people are here, that's why. In whole medicine, the difficult part is to manage fluid electrolyte balance. The difficult part is to manage fluid electrolyte balance. Rest pH balance is difficult. Once the fluid electrolyte balance, pH is disturbed. It is the difficult component. So, and all those guys, they are expert in this, in calculating fluid, managing fluid, converting fluid. Anesthetists are very good in it. Nephrologists are very good in it. They can manage all these things. Though they are good in it, and some diabetologists are very good in it, because in DKA, diabetic ketoacidosis, the patient dies just because of the fluid electrolyte balance. So they are very good and they are very smart in this. So here, iron, sodium, potassium, kullu ashya, they are absorbed, and then common pathway of the excretion with the help of the feces, kidneys, and then sweat. So this is the combination of everything. We start from here, tamam, stomach, duodenum, jejunum, ileum, colon, rectum, all these things are absorbed here, reaches to the blood, reaches to the liver, to the heart, and goes on. So if we just summarize it, mouth and salivary gland, what is the mechanism? Fibers, the mechanical action of the mouth and teeth, crushes and tears fibers into food and mixes with the saliva to moisture it for the swallowing. Carbohydrate, salivary gland secretes into the mouth, salivary amylase. Stomach, fiber is unchanged, stomach acid inactivate the salivary enzymes, so though the enzyme action of on the carbohydrate is stopped here. The small intestine, again fiber is unchanged, but pancreatic enzymes act on the carbohydrate and then broken down into smaller amounts. Large intestine, most of the fibers passes undigested, so it helps in the removal of the toxic substances and help in the process of defecation. Protein and fat, mouth, salivary, lingual lipase. Lingual lipase, sublingual salivary gland gives you the lingual lipase, salivary lipase or lingual lipase. Protein chewing and crushing action, they break down into protein, otherwise there is no enzymatic action. Then stomach, then acid stabilize the salivary lipase and split one into smaller bond, triglyceride are broken down. Here hydrochloric acid act on the protein and then broken down into smaller components, but not huge action is there. Then small intestine. Small intestine is the big bunch. Bile emulsified it, then you have emulsified fat acted by the pancreatic lipase, and then monoglyceride and fatty acid are released here. Similarly here, the polypeptide which comes from the mouth and which comes from the action of the stomach, they are here, and then we have many polypeptidases are there, and then pancreatic juices are there, and these peptidases are broken down into smaller amino acids, and then these smaller amino acids, they are absorbed. Large intestine, some fat and cholesterol trapped into the fiber and then removed from with the help of the feces. That's why those they are very much conscious of the weight, they are advised to have high fiber diet. This part is very important, because here this one, the large intestine part is very important, because here all the toxic things are there. So fiber has a very important role in removal of these toxic things, ammonia and rest of the other things. That's why the people, they are suffering from cirrhosis or liver failure, because they cannot convert ammonia into urea. So high level of the ammonia is there, and there is high chances of that this ammonia can cause toxicity. Now in order to stop the GI ammonia or GI toxic nutrients, you give them this fiber diet, as well as you give them some antibiotic, local antibiotic, so that kill the microorganism and to decrease the chances of more toxicity in these patients. Vitamins, no action in the mouth. Minerals, salivary gland, and again add into the water, stomach. Intrinsic factor is required to here for this vitamin B12. That's why in old age, when there is a gastric atrophy, this vitamin B12 absorption is decreased. Stomach HCl act on the act on the non-reduce and to reduce it, making it more absorption. The stomach secrete enough watery fluid, and with the help of chewing mass into liquid component, and this liquid component is called chyme. Small intestine, bile emulsified some fat soluble vitamins, although there is no much action of the water soluble, but they are absorbed there. Large intestine, bacteria produce vitamin K, which is absorbed. Here in the water and minerals, small intestine, pancreas, pancreatic juice add too much water, so almost 2 gallons are secreted into intestine in one day, which makes almost with the saliva and with the intake almost 9 liters. So, and most of these nutrients are reabsorbed. almost 90%, 6%, 92% and 6%, 98% is reabsorbed. This is just a quick summary for third year, because you had this earlier in the first year, even in the physiology. But now as it is the GI block, so we gave you just a quick summary. Just concentrate little bit more on it, that which component is absorbed where, and just correlate it with the clinical situation as I did right now. So for example, here we said that intrinsic factor and vitamin B12, when gastric atrophy is there in old ages, there. Nowadays H. pylori creates problem with this stomach HCl, and when there is a problem in the H. pylori, gastric ulcers are there, and again absorption, there is a problem in the absorption. Large intestine, you know that bacteria are there, too much bacteria are there, and these bacteria, they are responsible, they help in the formation of vitamin K. And if this vitamin K, so in one end, if you are giving them antibiotics, you should keep this in your mind, that if these antibiotics, they kill microorganism locally, they might kill those microorganisms, they are synthesized vitamin K. And as the person is suffering from liver failure, and you know that liver is the most important organ where many of the protein are synthesized. Many of the protein are synthesized, and most of the proteins, they may be involved in the regulation of blood clotting system. So if the liver is damaged and there is a problem in the liver, on the one hand the protein synthesis is jeopardized, on the other hand you are giving him antibiotics to control these toxic elements, you might come up with some situation where there is high chances of bleeding, bleeding. Yeah? So I mean, you have to correlate all these things. Again similarly, liver is fibrotic and is shrunken. When it is shrunken, you know that portal vein is coming into it. And when it is shrunk, so what will happen? The tension in the portal vein will be constricted. When the portal vein will be constricted, the tension in the portal vein will increase, and this leads to a situation that is called portal hypertension. And when there is a portal hypertension, so what will happen? There are some areas where there is a link between the portal and systemic circulation. There is a link between the portal and systemic circulation. I think there are 3, 4 or 5 areas where there is a link. I know some of them. One is the most common one at the esophagus, not here, esophageal, at the gastroesophageal junction. Another is at the anal canal. Third one is at behind the posterior surface of the liver. These are 3, 4 areas. You will see it, and you might form some other as well. So most commonly this area, when there is a portal hypertension, it bursts out. When it bursts out, so the people come up with the too much vomiting and blood vomiting. The people don't die because of this, because once they vomit and there is a rupture of the esophagus, the blood goes out. So what happened? Hemorrhage is there and the blood goes out. So what happened? The tension in the portal vein is decreased. When the tension in the portal vein is decreased, they close by themselves. But sometimes it is very dangerous. You need intervention. Earlier days we used to do surgical intervention. Then now modern days are there, balloon therapy is there. You just put a balloon, inflate it, so then it gives a pressure and then stop it. And now the pharmacological treatment are there. You just give some substances, particularly vasopressin, so it causes vasoconstriction. When it causes vasoconstriction, it can block this. So my advice is that whenever you are doing this, although it's very simple, it's not that much complicated, too much writing is there, but whenever you go one by one, carbohydrate, link it with the clinical things, protein, link it with the clinical things, fat, link it with the clinical things, vitamin, link it with the clinical things, tamam, minerals, link it with the clinical things. It will give you more good understanding. Clear? Thank you very much.
Thank you.
Okay.